Good morning. Thank you guys so much for allowing us to present our work today. These are our disclosures. So gastroesophageal reflux disease is a widely prevalent condition affecting up to 40% of adults in the US. Older adults typically present with less typical symptoms and less frequent symptoms compared to younger adults. However, they have a higher frequency of GERD-related complications, including Barrett's, strictures, and cancer. For those who are unable to be medically managed, some require surgery. So the purpose of our study was to evaluate any differences in the geriatric anti-reflux surgery population and to evaluate the effectiveness of robotic anti-reflux surgery in addressing symptoms in this group. We wanted to compare lengths of stay, complication rates, and need for readmission or reoperation with younger patients as well. So we performed a retrospective review of our prospectively maintained anti-reflux surgery database. We included patients who underwent an index robotic anti-reflux surgery operation between 2009 and 2023. We excluded those who had undergone prior foregut surgery and anyone who had to undergo emergency surgery. Those who were 65 and older were designated as part of the geriatric cohort and compared with patients less than 65 years old. So we had 628 patients in our study. About 2/3 of them were in the younger adult cohort, and 1/3 was in the geriatric cohort. Our geriatric cohort tended to be more female and had higher rates of diabetes, hypertension, and coronary artery disease compared to the younger adults. We didn't see a significant difference in BMI. For preoperative symptoms, we did see that our older adults had a lower preoperative GERD HRQL score compared to the younger adults, and they presented with less typical symptoms like heartburn and regurgitation. They were also less likely to be on acid-reducing medication. We saw equivalent rates of atypical symptoms between the groups as well as dysphagia preoperatively. On our preoperative exams, the older adults had more frequent and larger hiatal hernias on barium swallow. We actually didn't see that they had a greater incidence of esophagitis. They actually had less esophagitis than our younger cohort. However, those that did have esophagitis had equivalent grades. On preoperative manometry, the older adults had a slightly higher lower esophageal sphincter pressure, but comparable DCI, and the preoperative Demeester scores were also similar. As far as the operative details for our cohorts, our older adults were slightly more likely to receive a toupee fundoplication and less likely to have undergone a Lynx, a Nissen, or a Hill. They had significantly higher rates of callus gastroplasty and relaxing incisions. And interestingly, we noted that the preoperative and postoperative distensibility indexes on EndoFlip were significantly lower for the older adult group. Of note, our operative time was higher for the older adult group by almost 30 minutes, which, given the need for additional procedures, kind of makes sense. For our postoperative outcomes, our lengths of stay did not differ between the groups. Most of the patients go home same day of surgery. And 30-day readmission, reoperation, or dilation rates did not differ between the cohorts. For postoperative complications, our older adult group actually had fewer complications than our younger adult cohort, but those who did have postoperative complications had similar grades. Most of these patients presented with dysphagia or PO intolerance requiring IV fluids, antiemetics, sometimes steroids. Those requiring an additional procedure or dilation, needing some kind of additional procedure were similar between the two groups. We did have one patient that required ICU admission due to a leak, and that was in the younger adult cohort, and we had one death following an emesis event and aspiration in the older adult cohort. The postoperative GERD HRQL scores, both groups had a significant reduction from their preoperative values and were similar on short-term and long-term follow-up. And we didn't see any difference in the rates of new or worse dysphagia between the groups, short-term or long-term. So our study does have limitations. We were a single institution retrospective study, and we did perform multiple different RAPs, so it's a heterogeneous group. I also wanted to mention that the patients have been undergoing surgery for different reasons, whether it be symptomatic reflux or hiatal hernia alone. But in conclusion, we found that robotic anti-reflux surgery is a safe and effective option for geriatric patients with comparable outcomes to younger adults. And older adults do typically present with larger hernias and shortened esophagi, so Clinicians should just be aware of the need for possible lengthening procedures or relaxing incisions. And I'm happy to take any questions.